Hello and welcome, everybody. Thank you for joining me on this What's a Snowy Day in Ontario, Canada, and for part one of musculoskeletal mimics for lumbosacral radiculopathy. Part one is on specific disorders. When we do part two of this next month on March 20th, we're going to go kind of nerve root by nerve root, and some of it is overlap, and that's fine. It's just kind of a different way to think about it. And I wanted to welcome those of you who are here. The interesting thing about webinars is the global nature of who's joining us. So we had people registered from Canada, of course, that's where I'm from, all across the country, but also from, I wrote them down here. We have the United States, the United Kingdom, Mexico, the United Arab Emirates, which is super cool, Australia, and France. And last time we had a couple from Switzerland, but I don't think we have any Swiss colleagues here today. So welcome, everybody. Thank you for donating an hour of your time to join us live. And for those of you watching after, thank you for registering for this event. One of the things that I like about webinars and why I've started doing them regularly like this is it gives me an opportunity to go into a topic that may not fill, an entire video-based online course, for example, or some other form of content that I have to put a lot of time and effort and money into producing. But when I go through papers all the time, I read 40, 50, 60 papers a week and try and decide what to do with them. Like, do I do a research review on this for weekly reviews? Do I plug it into a slide deck somewhere, or do I file it for later? And this 1 hour format allows me to take a paper that I see that makes for a good discussion. And this webinar series, this two-parter, was based on a series of papers published in Muscle and Nerve, which, if you don't, frequent the literature like I do, it's a journal mainly meant for physiatrists and for kind of EMG diagnosticians. That's kind of the target audience for that journal. And they published a series of papers from our colleagues in Canada from Western University in London, Ontario. It's a group of medical doctors, most of whom are physiatrists, as far as I can tell, that wrote a series of articles about mimic conditions for lumbosacral radiculopathy. So that's why we're here today. So what we're going to do is start with defining lumbosacral radiculopathy, radicular pain, and a couple of other things before we get going. Then we're going to outline some differential diagnoses in the form of specific conditions that might mimic this in your clinic, and something that you need to be able to not only differentiate, but I also think keep in your thought process as you're doing your patient intake and your history, tailoring your physical exam and figuring out treatment interventions and monitoring response to treatment and so on. We're going to understand clinical signs and symptoms to watch for each condition. And my goal here, as always, is to sort of better our clinical thought process. And in this case, it's sharpening our differential diagnosis skills for something that we see quite frequently. And frankly, a lot of the conditions that we're going to cover today are going to become more and more common in your office as the population ages around the world, regardless of where you practice. So let's start, if we can, with defining lumbosacral radiculopathy and some of the other related terms that we're going to use as we go forward. Because I know in the literature itself, these terms are sometimes a little bit different depending on what you're reading, which profession is writing the paper, and so on. So I always like to start with what your patients are going to know and what they might come into you with. So just for fun, as I do, put in queries in Google sometimes and see what comes up if I'm behaving as a patient. And if I put in there that I have back and leg pain, this is what their now AI interface spits out for you. So it says back and leg pain, particularly when the pain radiates down the leg from the lower back, is commonly referred to as sciatica and usually indicates pressure or irritation on the sciatic nerve, which runs from the lower back through the buttocks and down the leg. Okay. This can be caused by herniated disc, spinal stenosis, or other spinal issues. So pretty generic. I wouldn't say it's inaccurate. I think it might promote the self-diagnosis with sciatica, but that's okay. I mean, not everything is pure sciatica. And we're going to touch on a couple of other conditions, piriformis syndrome, that not everyone has, and I think are somewhat overdiagnosed. When I first started looking at the quality and the nature of public information via Google and other sources about musculoskeletal conditions that we would deal with as chiropractors, the information 10, 15 years ago kind of sucked. And I think that's improving. And, I don't bore you with the papers, but there are some papers published where people go through this, like publicly available information that a search engine would spit out for you about back pain, neck pain, and so on. And that degree of accuracy is improving, which is actually kind of nice to see. So just something to keep in mind. And I think having a patient that comes into your office pre-educated about what's going on with them is actually helpful for us because when I first started practicing 21 years ago, I found you had to spend a lot of time kind of de-educating people about what they've read online or sort of correcting some of the falsehoods they have come across. I think it's also important before we get into the clinical definitions to discuss what we mean by mimic. And a mimic is a disease or disorder that produces symptoms like those of another. So it's exactly what we'd think it would be. And the reason these exist in clinical practice, and we can expand this concept from musculoskeletal conditions all the way through basically everything in medicine, is that only a disorder or a diagnosis or a disease or whatever that has tests available that are 100% sensitive. In other words, when a test is highly sensitive, it will detect that condition if it is present, and 100% specific, meaning a positive test means that you have this specific condition rather than also maybe having condition A, B, C, D, E. A non-specific test is positive for a whole bunch of things and is not very helpful at ruling things in. But a highly sensitive test, if it's negative, in other words, if it's not showing you a clinical indication, a highly sensitive test is good at ruling out a condition if it's negative. So I hope that makes sense. I know sensitivity and specificity are something that a lot of clinicians kind of struggle with the concept when they read it in papers. I mean, you guys all spend time reading papers, right? All the time. When I'm in person at chiropractic conferences, this is when someone yells out, like, that's what you're for. And I get it. Um, Being busy in practice doesn't really mean you're dipping into the literature too often. Secondarily, no condition out there, regardless of the branch of medicine that we're dealing with, has a 100% gold standard, first of all, definition, and second of all, a clinical test that's perfect. So, medical practitioners of all stripes deal with this idea. And this is where mimics exist. They exist in these gaps. And to complicate things even further, and I'm going to circle back to this at the end of the talk, is that all of the conditions we're going to talk about today can actually coexist with themselves and also coexist with other conditions. And I think part of the challenge in clinical practice is to get past this idea that everyone just has one thing. And I think as chiropractors, we're very much aware of this. And, that has to dictate our clinical approach. And it's also known, and they mention it in the papers, that some of these mimics can actually be synergistic. And, for example, an osteoarthritis of the hip can go along with arthritis in the knee, which can result in leg weakness, which can be a symptom of radiculopathy. You see where I'm going there. So I think part of our job as clinicians is to do a thorough workup and get to the primary diagnosis, but also be reasonable in our attempt to identify all of the different things that are happening with a patient. After all, I think that's what holistic healthcare is and what it's supposed to mean. So for the sake of what we're doing today, there's certainly a deeper dive to have here, and I recognize that. But for our purposes today, let's consider nociceptive back pain first. This is pain that arises from noxious stimulation and/or from pain generators in the lumbosacral region. This can be things like discs, ligaments, facet joints, facet joint capsules, bone, periosteum, joint surfaces, the sacroiliac joint, and all the surrounding ligaments and musculature. And myofascial just covers kind of everything else. We'll talk about myofascial pain syndrome in a moment. So nociceptive pain is just like regular pain. An injury or inflammatory pain can be a little bit different when it becomes chronic, but an injury or inflammation or something bothering a tissue causes that primary signal. That's what we're talking about with nociception, that your brain, I look at it this way. It's like your brain is interpreting that properly. It's a warning signal. If we move to somatic referred pain, as I'll tell you at the end, a great big portion of people with low back pain actually report coexisting referred pain into their leg or somewhere else in their body. And that means a noxious stimulation that produces pain that's felt in a region that is normally or typically innervated by the same level as the pain generator itself. The problem with referred pain, in contrast to radicular pain that I'll talk to you about in a moment, is it can be all kinds of things. It's usually more dull and achy versus the radicular type that can be a little more sharp shooting generally, and that's not always the case, and that's why it makes clinical life difficult for us sometimes. And it can be sort of migratory. It fluctuates. It's usually not constant. It usually presents in a non-dermatomal pattern, and we'll talk about the pros and cons of dermatomes in a moment. And it's thought, although I've seen this numerous times, where referred pain from the side of the hip, for example, can go below the knee, and we'll talk about that when we get there. But generally speaking, somatic referred pain related to low back pain is thought not to go below the knee, but I would put a huge asterisk beside that one. Radicular pain, on the other hand, is noxious stimulation or signals arising from an irritation or compression of a spinal nerve root. So this is considered to be a sort of classic scenario where spinal root issues are causing pain that radiates into the lower extremity. And the resultant clinical syndrome that goes along with that is where we land on radiculopathy, which refers to neurological impairment, including pain. But the pain, as you see in the second bolded bullet there, may or may not occur in conjunction with radiculopathy syndrome. So pain is not a required diagnostic thing, even though, as we know, it's usually there. So that's neurological impairment, kind of the syndrome, the combination of pain plus motor dysfunction, which tends to happen a bit later when something's a little more chronic, and sensory function, which in my experience at least happens a little bit earlier in a radicular syndrome or radiculopathy. And this syndrome combination of symptoms arises from an injury to or compression of one or more of the spinal roots. And our job sometimes is to try and pick off which spinal root is involved. And that's kind of the topic for the next one. I thought I would start with a little more generic in part one here. So we'll pick up on the nerve root concept in part two of this on March 20th. So what are some of the features of lumbosacral radiculopathy? The majority of them involve, as we're all well aware, the L5 and or the S1 nerve root levels. And that's simply because the L4-5 and L5-S1 discs are the most commonly involved in degenerative and pathological processes that result in discogenic back pain or progress from annular tear through the annular layers to a frank disc herniation, which of course is one of the most common causes that we're trying to differentially diagnose today. The most common combination, and again, huge asterisks here because the patients don't read the book. That's something I'd like you to get out of this discussion today. Most common presentation is this kind of radiating pain. It's a little more, I always say it's a little more sharp and severe than a referred pain, even though that's not always the case. Plus or minus some sensory alteration. And if it's dermatomal, folks, great. Maybe we can identify a spinal level. If it's non-dermatomal, that doesn't mean it's not radicular. That might mean there's more than one nerve root involved. That might mean there's multi-level disc degeneration and related degenerative changes to the ligamentum flavum or the facet joint that we're going to talk about in a moment. So we have to keep our minds open here a little bit. In the literature, it often refers to the pain associated with radiculopathy being neuropathic in nature. And whenever they study this, the descriptors that patients use vary quite a bit. So this is like burning, electric, sharp shooting, all that stuff that if a patient comes into us and says that their pain is sharp and shooting, generally speaking, I think we should pay a little bit more attention. And I think that's sort of standard approach for us. And not that other types of pain don't matter, but at least my clinical sense goes off when someone tells me that they're reporting this kind of pain that goes from one place to another in a big hurry with some level of severity. Unfortunately, neuropathic pain can also be reported as dull and achy. And I think that speaks to the idea of it becomes sharp shooting when you're in an anatomical position that actually irritates the nerve root to a point where those signals are overwhelming the dorsal horn and sort of amplifying the signal up to your central nervous system. Whereas the dull aching part can be when you're unloading that tissue or you're taking some pressure off the spinal disc, for example. And then concurrent low back pain. Generally speaking, again, none of this is perfect, but to land in a radiculopathy, normally there's some axial spinal pain first. It's very rare, in my experience at least, that someone goes from um, no neck pain, no history of neck pain, no history of a car accident or an occupational injury or history of recurrent back pain, for example, straight into a lumbar radiculopathy in the absence of trauma or in the absence of some pathological bone tumor or something that just reaches a threshold and then it's game over from that point. So if you look for this combination of kind of radiating pain versus referred pain plus concurrent low back pain that's usually been there for a little while, then the task becomes trying to pick off a specific nerve root if you can. So those are generally the features of radiculopathy. So hopefully we're clear on the definitions of what we're talking about. Now, when do you suspect this? When you're taking a history with your patients, what sorts of things are we looking to hear from them to start thinking of a lumbosacral radiculopathy? So here's a list with a couple of caveats on it. First, I think progressive nature is most common. That's just my experience. Interestingly, it doesn't show up much in the literature, but like I said, I don't recall seeing too many patients that go from kind of zero to hero in terms of no pain, no history of any back problem or neck problem into something that represents a radiculopathy. So progressive nature of the complaint, and this is where all the asterisks appear with the rest of the symptoms, because clinical radiculopathy can exist with or without radiating pain. The dermatomal distribution of sensory changes, like we all learn dermatomes, and I'll show you the dermatomes in a moment just for reminder's sake. But I got frustrated in clinical practice about the non-specific nature of them, and it was very rare that you'd pick off a specific dermatome. And when you did, you were like high-fiving yourself for all the education you got. And when you look at the literature about dermatomes, it becomes clear that they're not as crystal clear as we think we are. They're not, or that as we think they are. They are not as clearly demarcated across the human species as we would hope they are. And I think that takes a bit of pressure off us as clinicians. So dermatomal pain, if it's there, great. If that information and you can delineate those specific dermatomes to help you land on a specific nerve root for your diagnosis, spectacular. I would also add, does that change your treatment necessarily? And usually the answer to that is no. Um, Other things to look for: aggravation with coughing, sneezing, pressure, kind of Desjardins triad. The patient may report sensory loss, but if they don't report sensory loss, that doesn't preclude you from checking. Because I don't think a lot of people spend a lot of time thinking about what the sensation quality is from their shin, for example, or from the skin between their big toe and their second toe, for example, which is one of your cleanest shots at the L5 nerve root. So I think it behooves us to check anyway, and see if you can find some deficits in light touch. Sharp dull is usually what I would go to, because light touch is quite subjective for some people. And lastly, motor weakness. I think it's most of us are well aware that motor weakness, there has to be some nerve root insult there for quite some time before peripheral atrophy occurs in intraosseous muscles, for example, or in the foot, or you start seeing like calf circumference differences side to side. That's not an acute condition, that's a chronic condition. So if we're thinking of a more acute, fresh, new radiculopathy versus an old one, that's where the motor stuff may show up a bit more when it's been there for a while. So this is just a reminder about dermatomes. I borrowed this image from Netter, that those black lines on there in between the L2, L3, L4, L5, S1 dermatomes don't exist in human beings. And there is certainly multi-level overlap that is very common. People's ability to report sensation is sometimes not that good. As I said a moment ago, they're not always well aware of it if they're having a deficit there. So, what is interesting here, I think, are the autonomous sensory zones, which give you, again, with that asterisk, the cleanest shot possible at trying to identify one nerve root. The one I always use the most is the one between the big toe and the second toe as a clean shot, just like a motor test of the extensor hallucis longus is theoretically your cleanest shot at the L5 nerve root from a motor innervation perspective. We're going to go through all this stuff in part two. But just keep in mind, and I didn't include the studies here, but those of you who ever had me for this content at CMCC as students will remember looking at the studies where they compared actual human dermatomes to these Netter diagrams, and the correlation sucks, quite frankly. And it's not that all of the dermatomes on the Netter diagram are wrong. It's just that human beings are not that consistent in their neurology and in their anatomy. And I think it doesn't mean we shouldn't do it, just to be clear. I think it's good to do it, record it. And again, if you have a reduced patellar reflex and they have some sensory changes down the front of their shin and in front of their knee, great. You can sort of identify an L4, L5 problem and go to town that way. But I don't think we should really be upset with ourselves if this doesn't appear. Again, the patients don't read the book and neither does their anatomy. So that's just something to keep in mind from a dermatome perspective. And the literature is the same whether they look at upper limb or lower limb dermatomes. They're all equally probably not as great as we would all like. So let's get into the conditions they went through in these papers. And as I was putting this together, I was thinking maybe this isn't, a complete list, but these are the conditions they discussed in that series of papers. I think it at least gets our differential diagnostic wheels turning. And what prompted me to look at my current content that I have for lumbar spinal stenosis and maybe do a subsequent webinar on that is that might have been a condition I would include here. But I also think differentiating lumbosacral radiculopathy from lumbar spinal stenosis requires a bit of a longer discussion than what we have time for today. So I think I'm going to aim to do that. I can pull that lumbar spinal stenosis content from my older and bolder program that I did in person and as an e-seminar a couple of years ago because there are a couple of new papers there, but there's more to talk about there. So I'm not purposefully, or I guess I am purposefully excluding lumbar spinal stenosis from this list. But we're going to talk about facet joint degeneration and facet joint issues, myofascial pain syndrome, hip pathology, greater trochanteric pain syndrome, which is modern doctor speak for trochanteric bursitis. We'll dig into that when we get there. Piriformis syndrome, I think one of the most overdiagnosed things on the planet, in my opinion. SI joint dysfunction, hamstring, ITB syndrome, and plantar fasciitis. The last three there will be pretty brief because I think those are pretty easy to differential if you're doing a good history and exam. So without further ado, we'll get into facet joint arthropathy, which is like old doctor speak for degeneration. But let's just consider, again, these are medical interventionalists writing these papers, so hence the terminology in a couple spots. But I like to be true to the authors. Facet joints are thought to be involved in about 15% of low back pain cases, as every chiropractor smacks their forehead and says, like, it's way more than that. And I would agree with you, it's for the record. But I want to back up for a moment and talk about how we came to this number. The only way to actually diagnose a facet joint and a specific facet joint, in addition, is to do a double injection study. Yes. So that means an invasive thing where you stick a needle with an irritant into the L4-5 facet joint on the left, for example, and the patient says, ouch, that is the exact radicular pain syndrome that I'm feeling. And then you put a second needle with an anesthetic into that same facet joint, and the patient says, my pain is gone. That, folks, is literally the only way to fully identify a facet joint. So, Nikolai Bogduk, whom you've probably heard of, written textbooks on biomechanics and spinal pain for years. Originally, he and his group did those studies. These days, if I'm not on an ethics review board anywhere, but I don't think those studies would pass through an ERB at an institution because they're pretty invasive and can be sort of harmful. So those 15% numbers kind of come from those original studies. I think as chiropractors that move joints around a lot, I think most of us can at least confirm that the percentage is a bit higher. Most low back pain will feel a bit better if you get their facet joints moving better. And I don't think we've really captured that from a bench to bedside manner from a research perspective. But I think the involvement of facets is a little bit higher. But we also know that things like facet joint degeneration are very common. It can be part of a degenerative cascade that involves the IVFs and the disc and the ligamentum flavum and the vertebral bodies and all that kind of stuff. And that entire process is maybe a bit more of a talk for another day. But clinically, usually facet joints are thought to give axial pain. And remember, facet joints in the lumbar spine are about this far apart. There's also cross innervation level to level and side to side. So for us to be able to say left-sided back pain is from left-sided facet joints alone is a bit presumptuous, to be honest, and there is a lot of crosstalk there. And I think that speaks to a couple of things. Our diagnostic ability per level, like I always call it mechanical or primary now is the preferred term, primary low back pain, meaning there's no secondary disease-based cause. And I think it explains why most patients respond very well and happily to a chiropractic adjustment that releases multiple segments because you're probably moving the one that was most bothered and you're moving the other two or three that were equally as bothered. And I think we've all seen that in practice. And that gets us into a specificity argument, which is maybe actually that's another good webinar because there's some new papers out about that from Casper Nim and his colleagues in Denmark. Back to the facet joint, we're sort of left in clinical practice with no gold standard here for us to rely on. I mean, we can use Kemp's test, we can use motion palpation, we can use segmental, mobility testing, and those are all good things to do. But we have to recognize that none of them are perfect. I think part of our goal as clinicians, and I'll circle back to this near the end, is to um, recreate the person's symptoms. And if you can do that by challenging a facet joint or putting them in an adjustment position, like, oh yeah, that doesn't want to move right, and then adjust it, and then they feel better. Sometimes the response to treatment confirms the diagnosis, doesn't it? And I think facet joint is one of those things. Clinical tips for me, for what they're worth, make sure there's no nerve root tension because then you're looking for something over and above a facet. Doesn't mean the facets aren't involved. I think there's a lot to be said about facet joint involvement in disc degeneration because of the relationship between how discs bear load and how facets bear load. And maybe that's an additional point for another day. I talked about that in the disc program I did before COVID at in-person seminars. So always assess for nerve tension if people are reporting back and leg pain, and I think we would all do that. And one of my take homes at the end is to become very comfortable assessing nerve root tension and using the extended straight leg raise test and different modifications to try and identify nerve tension when it's present, because it gives you something you can treat with nerve flossing or nerve mobilization techniques. Make sure you palpate their spine. I don't have to tell a room full of chiropractors to do that. And also, does it respond to treatment? And, the decision matrix there gets a little more difficult when there's a facet joint degeneration and a disc problem. I mean, in all the clinical guidelines now, they've kind of combined back pain and back pain with leg pain in the absence of cauda equina syndrome or any other red flag condition, partly because the treatment recommendations are kind of the same. But adjusting patients with a known disc herniation is something that needs a bit of discussion with the patient, an assessment of your comfort level. I'm very careful about putting them in an adjustment position, saying, how are you now? Before, I'm not a small guy. So before I fall on you quickly and try and move things, how does that feel? And if they say, well, my leg doesn't feel good there, then I'm going to back off and mobilize or do some other technique. So I don't think we can say, hammer away on disc patients, but I think there's something to be thinking about if someone has an active disc problem or discogenic pain, is it not reasonable that they also have some facet joint degeneration that might respond well to manipulation, even if their disc pathology isn't necessarily going to be changed by that manipulation? So that's a nuance of treatment decision that I think we have to sort of address every day in our practices. Myofascial pain syndrome is another one. This is a tough one because it often occurs in conjunction with other conditions. I'm not sure I ever uniquely diagnosed someone with just this. And I'm not sure many of us do, quite frankly. For what we're talking about today, for mimics of lumbosacral radiculopathy, I want to point your attention to what I always called sciatica. And I forget where I heard that term in the first place, but it's when a patient has this like kind of upper glute, lateral glute yucky pain. And they also have a bit of achy weirdness happening at their knee or just below their knee on the front side or even at the back. And then if you get them side lying, pick up their hip and let them rest on your leg, for example, and palpate in their gluteus medius and or minimus, you can actually recreate that pain. I always called that sciatica. Got a good laugh out of the patients because normally they would come in and tell me they had sciatica. But that's a myofascial pain syndrome. And this includes pain generated from myofascial structures, fascia itself, but also the presence or absence of trigger points, which I don't want to get into this too much today, but trigger points are often a thing, in my opinion, for people that have that pathology. I don't think humans homogeneously experience trigger points, but everyone on this call, everyone watching this recording after, will have palpated a trigger point in a patient that refers pain to that exact same spot that's on your diagram on the wall, right? You guys have all seen that before. But when you look for those spots in every patient, you don't find them, do you? And I think we just have to wrap our heads around the idea that it's a pathology that some patients just don't have. So that explains the wishy washy results you get in the literature when you try and study it and treat it. You can't go into a trigger point study assuming everyone has trigger points. I think that's incorrect. So there's my side diatribe on trigger points. The cause of myofascial pain syndrome is poorly understood, to say the least. It could be inflammation, it could be an injury, could be sustained contraction or muscle tension from occupational or repetitive strain injury, could be resultant or associated ischemia, or central sensitization. It could just be a nociplastic pain sensitization process dictated by central nervous system changes. And ultimately, folks, these are all just theories. But again, I challenge you to find someone with a chronic spinal condition, for example, that doesn't have some degree of myofascial pain syndrome happening. And regardless of the mechanism, just to be clear, I think it's a valiant thing to try and address and treat. And quite frankly, some people respond very well to trigger point treatment with dry needling. I mean, I've done acupuncture my whole career. So if you find it and get it and it relieves it, great. But acupuncture, as you know, too, doesn't work for everyone either. So it's a matter of finding the right combination of treatments that work for the patient in front of you. Known risk factors for myofascial pain syndrome are all over the place, but include being sedentary, vitamin deficiencies, Lyme disease, hypothyroidism, poor sleep, and psychological stressors, which just makes the bag of possibilities enormous. So again, that speaks to the generalities in that literature around myofascial pain syndrome. Let's move into the hip for a moment. If you have a patient with back pain and referred leg pain, particularly in the front of their leg, I need you to start thinking about their hip. I think chiropractors are often so interested in the spine, and that's fine. The spine's really cool. And so is the lumbopelvic junction. But I think sometimes I've seen cases that used to come into my office that had seen other chiropractors that clearly had a hip problem and were being treated as if they only had a spine problem. So the hip can refer to several locations. One of the things I want you to think about today is hip osteoarthritis, which is a common mimic or a comorbidity for lumbosacral radiculopathy that can result in pain and weakness, and specific leg weakness like hip flexor or hip extensor or knee extensor mechanism weakness that can sort of mimic a radiculopathy syndrome. It's usually insidious long-term onset that initially shows up when the patient's in motion. It feels a bit better when they rest, and eventually it can progress to being painful at rest as well. The problem with the hip is it can refer just about anywhere, including the groin, the thigh or the knee, the buttock, the posterior lateral hip area. They can have pelvic pain depending on the degree of degeneration and the part of the hip joint complex that's involved, or even to their shin in some cases. As a clinical indicator, look for that reduction, that capsular restriction pattern that you see in a hip joint with reduced hip adduction and internal rotation. And I put capsule tension, and that's just, I would always have a supine patient put their knee in my armpit and just move their hip around in a P to A force manner and see how their joint feels and compare it to the other side. I think we have to get really good at assessing hip joint feel as chiropractors. And from my perspective, at least, I've done presentations at conferences about this, about the relationship between the hip and the knee, or sorry, the hip and low back pain. And I think I would often start my low back pain assessment with a hip to see if that's a potential contributor before I get to my opinion about what's going on a little bit higher. Also, look for matching age with their injury history and their symptomatology. And remember, imaging findings in the hip don't always correlate with clinical severity. I'm going to go quickly over this one because they included it in the paper, but I think femoral acetabular impingement in the hip and labral pathology is much, much less likely to mimic a lumbosacral radiculopathy, partly because they're going to have mechanical hip symptoms right in the hip joint. And it's going to be younger patients, even though, lumbosacral radiculopathy trends in younger patients, but hip pathologies like this trend in patients that are even a bit younger, like 20s and 30s, before people get to the age where disc herniations start to become a little more prevalent, and lumbosacral radiculopathy tends to happen a little bit more. Forgive me, I'm speaking in generalities, but that's just the way it goes. From a clinical perspective, you want to identify the injury mechanism. This will be someone who does, martial arts is a good example. Figure skating is a good example. Anything that requires high range of motion, high load hip movements with impact, they can be at risk for tearing their labrum. And depending on their anatomical setup, whether they have a pincer deformity of their acetabular shelf, or roof, or a bigger acetabulum, a bigger femoral head, like a cam deformity, those can predispose people to these sorts of symptoms as well. You're also going to be able to reproduce their symptoms with clinical testing like hip impingement tests, the flexion, adduction, internal rotation. You're just basically taking their hip and trying to, it sounds mean, but you're trying to grind it a bit and see if there's a catch point there. And you can usually get to that with clinical testing. A good time to circle back to another point I made earlier, that these sorts of conditions can occur in conjunction with mechanical back pain or lumbosacral radiculopathy as well. But these generally, I think, are a little bit younger patients, and they tend to stand out from an injury and a mechanical perspective. Now, sciatica, I'll get to as an overdiagnosed condition, but hip bursitis, my God, everyone with lateral hip pain thinks they have hip bursitis. So much so that in the literature about 15 years ago, they changed it to greater trochanteric pain syndrome to include pain and pathology from other structures, which includes the gluteus medius and minimus, which in my opinion is way more common than an actual bursitis, and also the iliotibial band, which of course overlays that whole area. GTPS as a diagnostic category refers to pain that can radiate to the lateral hip or thigh, even going past the knee. Generally increases with activity, including running, long standing, cycling, that sort of thing. And these patients, if they have bursitis, which is still some of them, but not as many as the people that think they do, they'll be able to point to it with their finger, and you'll be able to put your finger right on their greater trochanter and go around the bony bit, because there are multiple bursa there in some people. And, just as a reminder, bursa aren't these like nice balloon shaped structures that they show in anatomical diagrams sometimes. If you go back to your anatomy dissection days, they're basically, think of them as a balloon with a bit of dish soap in them. That's what a bursa is. And they can become inflamed. They get a little swollen sometimes. I get that. But I think generally speaking, they're not as involved in lateral hip pain, generally speaking, as some of the other structures. So this is a condition where the patient will tell you some things about the nature of the pain. If it is bursitis, that's in my experience generally a little more burning, a little more sharp. But if there's no pressure on it at the moment, it's not that bad. But then if you go and palpate that area, it lights it up for them. So make sure you're good at palpating the structures in that area. And if you slide half of a thumb width off their femoral greater trochanter and you're in the meat, that's probably not a bursa anymore. And then you're starting to look for myofascial tension, trigger points, and that sort of thing. You can also get them to resist hip external rotation or abduction to try and get at that area from a muscles testing perspective, and also use single leg stance. I found that one was hit or miss, quite frankly. This sort of condition is usually a palpation diagnosis for me. Clinical correlates with greater trochanteric pain syndrome. It's much more common in females by about 3 or 4 to 1, depending on where you look in the literature. That's probably a pelvic shape issue. That would be my guess anyway. It also correlates with iliotibial band tenderness, and especially if that condition has been there for a while, that's probably a central sensitization issue. And it also happens to correlate commonly with low back pain and knee osteoarthritis, which to me brings us to a regional anatomy kind of argument and a regional interdependence, uh, suggestion that we should be looking at various areas in these patients. So this is as a slide I used in my CMCCs lecturing on hip conditions for students for years. And it just takes that all, it's just meant to show us that all lateral hip pain is not bursitis. True bursitis is actually probably a small proportion of lateral hip pain. I think it's much more related to gluteal tendinopathy most of the time, especially depending on where the exact pain location is. Remembering that lateral hip pain can also be referred from a disc, from a nerve root, from a facet joint, and so on. One thing I didn't mention earlier that I'll circle back to facet joints is those same injection studies showed us that they can refer pain just like a nerve root can in similar areas most of the time. So just something to keep in mind as well. And we'll circle back to that in a moment. Next, piriformis syndrome. This is super overdiagnosed, and it's like muscle racism against the gemelli muscles and the obturator internus, because the piriformis is basically the size of your thumb, but the area of pain that we're palpating in people's glutes is like this big. There are other muscles there, folks. The terminology is less important than finding it and finding a motion or a treatment to fix it. But I think we blame the piriformis for a ton of things that are actually sometimes the quadratus femoris or some of the other hip external rotators there. So don't forget, the piriformis does not cover the whole ass. It's only part of the ass. Okay. If you take anything from today, take that. When it is there, there's no universal diagnostic criteria, quite frankly, which is surprising based on the commonality with which you hear this diagnosis. It can arise from trauma to the area, hypertrophy, spasm of the piriformis itself for whatever reason, prolonged external pressure, or tissue congenital anomalies. I remember when we learned about this in school, it made us think that everyone has a bifurcated piriformis that, clamps down on the sciatic nerve as it goes through. But what they've discovered is that even people who have those anatomic anomalies don't necessarily have piriformis syndrome. So once again, those things can matter. I'm not saying they don't, but we have no way of knowing that that's a thing for a given patient anyway. And again, it doesn't really change our clinical assessment and treatment. These patients generally have buttock pain with or without leg pain. It's worse with sitting and driving. And if it's the right foot in Canada or anywhere really, driving can be a little bit worse for them. And that's often what we'll see. This is a palpation diagnosis. The piriformis is when you drop down off their greater sciatic notch. Your thumb, remember, piriformis is the size of your thumb on a regular sized patient. So when you drop off the greater sciatic notch, that's it. If you go above or below that, you're on something else. That doesn't mean it can't be involved. And I would always assess that both statically, but also with hip motion too, because sometimes you need to get a muscle to a degree of length before you find the spot that is giving them the problem. And if you're adept at soft tissue techniques, you probably use that strategy in clinic as well. What about the SI joint? This could be a webinar topic too. Look at all the ones I'm finding today. SIs are thought to be involved in about 10 to 40% of low back pain. And your patients, if it's the primary pain generator, will often point to it. Like, it hurts right here just below my belt. And you're like, yes, I know what that is. The risk factors for sacroiliac joint dysfunction are mostly biomechanical. They include leg length discrepancy, that's LLD, transitional segments, scoliosis. It's also very common in pregnant women, posterior pelvic pain, of course, and mostly biomechanical anomalies, with the big asterisk that just because they have a biomechanical anomaly does not mean that they will have SI joint dysfunction. And, these are all clinical correlates to put the story together. And it's part of being responsible and avoiding the temptation to anatomically body shame people by saying you have a short leg, therefore your SI joint is prone to X, Y, or Z. We have to be careful how we message that to people. Common pain referral pattern from the SI joint is into the buttock or over the SI joint itself, but also into like the lateral thigh. Some people get anterior, some people get posterior. And depending on the person, it can actually refer pain to the groin as well. You want to look for a side. It's again, you're generalizing here where I am, but Usually SI joint problems are one side, kind of like hip problems. You're going to have one hip that's just really worse than the other one, that's contributing to things. So I don't think the absence of midline pain that was in the papers. Now that I'm saying it out loud, I don't know if I love that, but usually the SI joint pain will pick a side. If you distract the SI joint, have them supine, push on their PSI or ASISs rather from the front, that should help. And the SI joint is about diagnosing it with a combination of positive tests. There's no one perfect test for the sacroiliac joint. But over and over again, Laslett and his colleagues and some other research groups have found that if you use thigh thrust or Gaines lens, or there are a few other ones as well, as soon as you get up to three of them that are all pointing you in the same direction, our diagnostic accuracy goes up compared to gold standard, which is usually injection, which obviously you're not going to do in your practice. I think dorsal sacral ligament palpation should count as one of those tests if that's sensitive. Um, and you're relatively convinced that it's not a cutaneous nerve problem from a bit higher in the lumbar spine, it's just the ligament itself is sensitive. I usually added that to my algorithm as well. So that's just some ways to get at the sacroiliac joint. Now, the last three things, and then we'll wrap it up with kind of a regional summary. Hamstring pathology, I don't think in an acute environment will mimic a lumbosacral radiculopathy unless someone already had a lumbosacral radiculopathy in the making, if that makes sense. But it's the chronic hamstring tendinopathies that can kind of mimic this because, you know, tension, fibrosis, tendon issues in the hamstring because of the proximity to the sciatic nerve can actually give you some referred pain. And in a really bad scenario, it could actually cause some fibrosis that would bother the sciatic nerve as it traverses that area of the body. So if you have an acute hamstring strain, it's probably going to be pretty easy. There's going to be a mechanism of injury. As a side note, the more proximal a hamstring strain, the longer it's going to take to recover. So that's something to communicate with your patients. And in a tendinopathy or a more chronic sense, there's generally vague pain that's worse with activity, at least initially. And that pain can kind of travel a bit. And that's where we get this lumbosacral radiculopathy mimicking. But I think you can use your history and physical exam. You can palpate the hamstrings. You can look for nerve root tension versus hamstring pathology, recognizing that you could have both, depending on the patient and their mechanism of injury and their occupational needs or how much time they spend sitting and so on and so forth. So something to keep in mind. The last two I put together because I don't think they're that difficult to differentially diagnose for lumbosacral radiculopathy. The first is IT band syndrome. The exact pathology for this condition is also controversial, whether it's a friction or compression issue. It's normally associated with biomechanics, and I'm okay with that for the most part, but I also think there's a huge central sensitization or nociplastic change contribution to that condition in most patients. It's common in runners or cyclists or those who do repetitive activities. They can get this kind of sciatica feeling. In my experience, for what it's worth, folks, using Graston tools or instrument assisted soft tissue treatments, the big handlebars like scraping over people's IT bands, it just irritates the crap out of them, I think. So I stopped doing that years ago. And I focus my soft tissue work up in the glute med, glute min, hip rotators, mobilize the hip joint, and almost leave the IT band alone. And the same, I think, can be said for foam rolling. Like some people are like smashing their IT bands on a foam roller, and it's always sore. It's kind of like hamstring stretching. Like, doc, why are my hamstrings so tight? I stretch them all the time. Like maybe you should work on hip mobility or, controlled ranges of motion versus static stretching. So we have to be careful what we do with the IT band because I think some of the harder manual therapies can almost sensitize it more. I don't know if you agree or disagree with that, but we can talk about that after for a few minutes if you like. The other thing they include in the paper was plantar fasciitis, which is about 80% of patients with heel pain have some degree of this pathology. It involves inflammation, compression, degeneration of tissue, or again, central sensitization, where the brain is just more likely to perceive pain in an area. It's identified by non-radiating plantar foot pain without paresthesia. That's what it said in the paper. I can tell you, I've seen plantar fasciitis patients with a bit of numbness in their foot. They may or may not have had something going up higher. If I see that numbness, I'm looking at nerve entrapment sites a bit closer to the knee or up into the hamstring or hip region for what that's worth. Symptomatically, these people normally have localized plantar pain that's worse in the morning or after they've been sitting for a while. It's bad for the first few steps, and then it kind of tends to ease off. And the pattern otherwise can follow a tendinopathy progression where it's fine at rest, sore with activity, and then that almost switches over time to be sore all the time. So plantar fasciitis can be a tough one. Um, had some patients in my practice that really respond well to acupuncture, but depending on their foot, you have to like jackhammer needles in there. But if you can do that, that can respond well. Soft tissue techniques, mobilization and adjustments of the foot ankle complex, and also fascial chain attention more proximally. If you're struggling with someone with plantar fasciitis, make sure it's kind of weird, but I noticed it over the years. Make sure their tib fib joint, the proximal one at their knee, is moving properly. Sometimes, if you compare those side to side, you'll find that that's really not moving in someone with that's being a little bit difficult to treat for their plantar fasciitis. That leads us into Monday morning advice here, some clinical considerations. So, we're dealing with some realities here, folks. One of them is that we're considering musculoskeletal differentials for lumbosacral radiculopathy. We didn't talk about peripheral nerve issues and some other pathologies. These papers focused on musculoskeletal stuff. I think that's appropriate for us as chiropractors. So I hope this discussion has been useful for you. And I'll remind you that many conditions can result in pain, of course, including local pain up in the hip and the pelvis and the low back, but also pain that goes somewhere else. And it either goes, vaguely and intermittently, or it goes sharply in a defined pattern. And weakness and sensory changes can occur as well. We have to also be mindful that multiple conditions and pain phenotypes can exist at the same time. So someone could have a lumbosacral radiculopathy from a disc herniation and also have, as I mentioned earlier, facet joint arthropathy and degeneration and pain coming from there that can amplify the lumbosacral radiculopathy and so on. And I think we have to be very mindful of that patients are allowed to have multiple conditions. They don't read the books and don't, in my experience, hardly ever come in with a perfect root specific neurological pattern. And we'll dive into that a little bit more in part 2 next month. The literature tells us that about 2/3 of low back pain patients have some sort of referred pain. So they have pain in their back plus somewhere else. And that's often thought to be somatic referred pain, as we referred to earlier. And lumbosacral radiculopathy is thought to occur in 3 to 5% of your patients. It's like meaningless epidemiology because 3 to 5% of the population does not necessarily represent the percentage of people who have decided that I need to get help for this. So I always find numbers like that. That's not representative of your practice because probably we're going to see the people who have decided to get treatment or help for it. I want to remind you when we're talking about lumbosacral radiculopathy about the treatment alternatives. The medical profession tends to over-image these people. They tend to refer them for surgical consultations way too often. There's big data on this now. This isn't just a chiropractor whining about it on a webinar. And they also prescribe medications for it, like opioids, benzodiazepines, and gabapentin for lumbosacral radicular pain. And we finally have some ammo from a chiropractic perspective. Robert Traeger from the United States has done his PhD work looking at these huge healthcare system databases in the United States and identifying that seeing a chiropractor for spinal manipulation for lumbosacral radiculopathy can greatly reduce the prescription rate of gabapentin, benzodiazepines, and opioids for lumbosacral radicular pain. I've reviewed all those papers on my service. I might dedicate a webinar down the line to these big data studies so we can appreciate the pros and cons of them. As with other research, nothing's perfect, but at time after time after time, these databases with hundreds of millions of people now from a big data perspective are starting to show us the same answer. So let's be a bit mindful of the treatment alternatives. I think manual therapy is a good option, or at least conservative care for these conditions. And if we did that with every patient, putting my healthcare administrator hat on now, we would save bazillions of dollars for the healthcare system in North America and Europe. So just to review quickly before we finish up, and if you have to bounce at 1 o'clock, that's fine. I will stay on for a few minutes and answer some questions if you like. And but I do clip the questions off the recording, generally speaking, for when I send it to those that couldn't be with us live. So we'll finish off with a bit of a symptom location and differential list. And remember, these are conditions we're trying to differential from lumbosacral radiculopathy. So just keep that in mind. If they have flank pain, you're looking at a facet arthropathy or facet joint referral or degeneration or myofascial pain syndrome. Groin pain could be any number of things, including hip osteoarthritis, depending on the age and stage of the patient. Labral pathology, if it's a younger person with mechanical symptomatology. Facet arthropathy, sacroiliac joint can refer to the groin in some patients, or also myofascial pain syndrome. If it's groin pain plus anterior lateral thigh, that's when you're looking at hip pathology. I would also add sciatica and the gluteal musculature to that as well. Buttock pain can be piriformis syndrome or the gemelles and the internal in obturatus internus. Hamstring tendinopathy, sacroiliac joint, myofascial pain syndrome, or greater trochanteric pain syndrome. Buttock plus posterior thigh can be referral from the piriformis or hip external rotators. Hamstring tendinopathy or SIJ, myofascial pain, greater trochanteric pain syndrome. Buttock plus posterolateral thigh. I added the posterior there because I've seen that is SI joint is a consideration. This is a second slide, same chart. Lateral hip and lateral thigh can be greater trochanteric pain syndrome, facet, referral, or myofascial in nature. Anterior thigh is a common referral site for hip osteoarthritis or labral pathology or something internal in the hip joint itself. Lateral knee is can be facet arthropathy, iliotibial band syndrome. It can be internal derangement in the knee itself. It can be a capsule problem with the knee. Could be a plica syndrome. Could be a number of things. They didn't really dive into knee differential diagnosis there, but just to add those couple. Plantar foot is often plantar fasciitis. Uh, Heel spurs are another thing that can occur there, obviously. Lateral foot is facet arthropathy. I would add fibular nerve entrapment there. That's common. Look up around the proximal tib fib joint or up higher in the hip to see if you can find something in patients with lateral foot pain with no other explanation. And if something refers distal to the knee, greater trochanteric pain syndrome, pain goes below the knee in about 50% of patients. And in the sacroiliac joint, it goes below the knee in about 30. And that's based on, not amazing evidence, but that's the numbers that show up in the literature. So that's just kind of a review. On exam, what do we do here? We obviously observe people, look for antalgia, general sensitivity with movement, weight bearing deficiency. I always look at quality versus quantity of range of motion when I'm thinking about the hip joint specifically. We're good at palpating for segmental stiffness and function. Become very, very good at assessing nerve root tension, lower limb neuro exam, of course. And if you're so inclined or trained, you can get into your loading profile assessment via mechanical diagnosis and therapy or McKenzie. And don't forget the hip. And also, what you do in your exam should formally inform your treatment. And I think that goes without saying. A couple more slides here. The need for imaging, you can diagnose lumbosacral radiculopathy without imaging. Normally, imaging is obtained along the way if the patient is not responding to care or if they are being seen by a surgeon. The surgeon will certainly obtain imaging. So you can diagnose disc herniations and so on without that. I just want to finish with a couple of points about patients, practice, and procedures. For your patients, history taking is critical to get to the right answer. Get their loading in injury history and profile. Look for pain patterns and characteristics. Start your phenotyping early. And I think Dr. Asimakopoulos and I will talk about phenotyping in a subsequent webinar to help us understand that. And we have courses on the platform that I offer about that. Gather information to customize your physical exam. Remember that lumbosacral radiculopathy and its mimics can coexist, as I mentioned earlier. Get a working diagnosis. It's okay to leave multiple diagnoses, folks, even from a medical legal perspective. To me, it means you're thinking about what could be there as opposed to what you're fully confident is there. Always be aware of emerging neurological symptoms. From a procedure perspective, again, with my medical legal hat on for a moment, make sure you document your neurological exams on intake and on your reevaluations. It's always good to show that you're monitoring their neurological status. Get very comfortable assessing nerve tension with straight leg raise variations, ankle dorsiflexion, toe dorsiflexion, head and neck position, slump testing, and all that sort of things. And combine your test results to increase your diagnostic accuracy. That goes for radiculopathy diagnosis, trying to establish an involved nerve root level, diagnosing sacroiliac joint dysfunction, as I mentioned earlier. The more positive tests you have, the more confident you can be that it's pushing you in the right direction there. It's all about putting the pieces together from a clinical history and intake perspective, your physical examination, being comfortable in your mind, ruling in or out things in your interaction with the patient, taking into consideration everything that goes into how they landed in your office. So that puts us just about on time. A lot of you are already signed up for part 2 of this webinar, but if you're not, it's on Thursday, March 20th, same time, same station, same recording will be available afterwards. And we're going to do a nerve root analysis and add a couple of other differentials to things that can mimic an L1, L2 radiculopathy, for example, and get into the further examination of that thought process. So there's a QR code to sign up for that, or you can just go to the webinars page on my website. And with that, I will thank you for attending. I'm going to be coming out soon with more YouTube content, so you can be in the Founders Club, the first 1,000 people to follow me on YouTube, trying to balance the equation for what's going on YouTube from a chiropractic perspective. And if you want to stick around for a moment, I can stay and answer some questions, but thank you for your time and attention. I hope to see you at subsequent webinars, and I'll speak to you next time.